transplant, we don't do there. So again, each provider entity, whether it be a community hospital, academic medical center, or anywhere in between, their degree of willingness to accept or not a bundled payment or an accountable care organization or a value-based risk contract will vary based on their, provider network, their degree of sophistication with analytics and financial modeling, and their patient base.
Yeah, and that actually brings up another question that we were actually just about to ask, which is do you have any perception on just how you would characterize like the success of the ACO model to bundled payments, or is it even the right way to think about those, to compare them, or are they just such different models of care that they don't really make sense to like compare apples to apples?
They are sort of apples to oranges, but even within the ACO world, Medicare had a bunch of pilots for ACOs, and many of them failed. And they failed for a variety of reasons. One was physician leadership. One was internal cost structure. One was, non-aligned incentives between the hospital and the medical group. So, it gets very complicated very quickly. And I used to joke, you've seen one contract, and you've seen one medical group, you've seen one medical group, because they're all different. They all have nuances in terms of leadership, allegiance, exclusivity, quality, aligned incentives. So there is tremendous opportunity and potentially tremendous risk for going down the path of managed care and, bundled payments in ACOs, depending on how good or nimble an organization is with regarding to analyzing data, interpreting data, and then course correcting if they find an adverse trend. But I think in terms of what your question around ACOs and, bundled payments, I think, clearly something has to be done to bend the cost curve. And these are both sort of experiments and or pilots in that realm. And I think they will only continue to grow. But again, there's not a one size fits all. So you will see a degree of variability across regions, across networks, across types of providers.
And then is there a world in which, obviously ACOs have their own structure and their own sort of unique requirements within the actual organization. Is there a mechanism with which, like, where an ACO would also be doing bundles as part of just their ACO? So, like, I guess what I'm asking is, like, does being an ACO negate the need for a bundle, or is that still an opportunity for bundles to evolve in that environment?
Yeah, there is an opportunity for it to evolve in that environment. And remember, if you have an ACO, for example, Banner Health, they are, an ACO with Aetna, but they're not necessarily an ACO with United, Cigna, Humana, HealthSpring, Molina, whatever. So, right. So it's a hospital and a medical group. They are in an ACO arrangement with one health plan for potentially one line of business, meaning commercial, fully insured. They may or may not do that for self-insured or, Medicare or Medicare Advantage or Medicaid or managed Medicaid. So just because you've said the word ACO doesn't mean it's all health plans, all lines of business. So you can still have bundled payments with other payers in that model. And I've even seen independent orthopods saying, I'll do your hip for $25,000 or I'll do your, whatever. And they, so it's sort of like a flat rate fee where they're advertising to get patients, and you've seen this sort of in the dentistry world where, braces for, $5,000 or whatever it is. So it's sort of, the service plus all necessary care surrounding that for a period of time is covered in that sort of bundled payment. So, you kind of see that in terms of, bariatric surgery bundles, if you will. So there are, different models where you can say, here's the flat rate and this is what you'll get, and you'll get the appropriate post-op care or